Okay, I think we're ready to get started, everyone. Please continue to enjoy your lunch, and we're happy to get you going on the next stage of things. Okay, howdy. Yeah, I forget, you have to say howdy. Howdy, everyone. My name is Dr. Lynn Vartan, and I'll be serving as the moderator for this session with this fantastically alien microphone, but we'll do the best we can. I think we do need the mic, right? Without it is... Yeah, it's... Okay, yeah. Well, it has a little bit of a funny thing, this microphone, but yeah, we'll start with it and try further away and see how it goes. Okay, so I'm going to get started. We have 4 panelists here, and we'll get a conversation going as soon as possible. We each have about 7 minutes to present our work, and I'll start with what I have going on. This is the group that you're going to see, Dr. Jay Lee, Dr. Zena Trost, and Dr. Brian Kim, and myself, Lynn Vartan, and here we go. My project is first. Many of you know me, but for those of you who don't, I'm an associate professor in percussion interarts performance. So my area is music, specifically with all things rhythm and drums, etc., etc. Most of the time I am combining music. This mic is really very unusual. Is it okay without? It's fine without?
Yeah.
Okay. I think it's more distracting, yeah? No worries. Okay, we'll all use our theater voices. Most of the time you all see me mixing and matching live performance with music and dance, music and theater, music and visual arts. But one of the projects that I'm involved in right now, which we're finishing the setup of the lab, and we're hoping to launch in the next 6 weeks. The project is called Sanctuary Space, Improving Wellness Through Music and Visual Immersion. When I first came to this campus, I came with a little bit of background on getting deeply into mental health on college campuses for students. So I was particularly turned on by the woman's question when she was, the last session was asking about what is being done for mental health on campuses. And this has been an interest of mine, and I've developed curriculum for it. We developed some resilience curriculum based off of the work of Angela Duckworth and all these kinds of things. But what else could we do? And also combining music and nature was also pulling at me a little bit. And so when I got to campus, I got involved with Dr. Jay Maddock at the Center for Nature and Health. And they didn't have any artists involved. And so I got in there and we started talking, and I explained this idea that I have for something called a sanctuary space or sanctuary pod. Again, it's a little bit related to the sanctuary spaces that you saw in the last presentation that they had during COVID. So I'm excited to learn more about how those did. But this idea is that anybody on campus, but particularly students, but also now we've found that staff, faculty might be really interested in this as well, could go to an enclosed space. You could basically book time in the sanctuary pod and have a combination of visual stimulation, particularly nature. Let's say you're from a beach town and you're really homesick, and that could be something really powerful for you. So there would be visual spaces that you could then be a part of and spend time in, but also how could you participate in music? And so this idea had been percolating, and I'm a percussionist, and we have a brand new instrument on the market right now called the Jewel Marimba, which is a keyboard percussion instrument that is really meant for everyone, and it has a very special tuning, which I'll tell you a little bit more about. So all these things came together. We've got a bunch of people that are excited about it, and we applied for one of the targeted proposal teams grants on campus and got it. So this is the study that is underway right now. This is the rationale for the study. Mental health and wellness are a national priority in higher education, particularly regarding strategies to reduce stress and anxiety. Since the COVID-19 pandemic, rates of poor mental health have reached epidemic levels. Contact with nature and music engagement have each been shown to reduce stress and support positive mental health. However, few studies have rigorously tested the combination of these approaches to protect individuals' mental well-being. This project aims to develop a program that integrates music and healing sound to create small sanctuary spaces where individuals can effectively manage anxiety and stress. Specifically, the study aims to examine the psychophysiological benefits of nature and music by exposing college students to natural landscapes while they engage with a musical instrument. No prior musical experience or training is required. This study will explore how these combined experiences influence stress, anxiety, mood, and overall well-being. And ideally, something that people could do on their own. You don't need to have any kind of structure to it. You would just go into this place. So that's the rationale for it. This is what the protocol is going to look at. We're setting up the lab right now. This is the instrument covered in the space. I'll tell you a little bit more about it. Eventually, we would hope, based on this study, that we could build an all-inclusive space, but we're starting with sort of a half version of it to get going. So we're doing pre-intervention assessments. Participants will complete a survey measuring stress, anxiety, mood, connection. Heart rate and blood pressure are also going to be recorded before the intervention. We are going to randomly assign participants to one of 4 conditions. So we're hoping for a pool of 300, which is adventurous, but we're excited about it. The control will be watching a busy cityscape in the space without the instrument present. One will be music only, playing this instrument, which I'll show you. Again, no prior musical experience required. Another version will be nature only, just the nature with sights and sounds, not the instrument. And then the last will be combined with the music and visual. So we're going to randomly assess people to one of those 4 experiences. And then the post-intervention assessment is that afterwards, we'll do, again, a survey on stress, mood, quality of experience. Heart rate and blood pressure will again be recorded after by research assistants. So that's kind of the baseline of it. You're going to have the control will be busy city. You're going to have the either music only, we're going to have nature only or visuals only, and then the combined to see what happens. Okay. So the Jewel Marimba was one of the essential elements here, and this is a little bit about what it's about. This is what the instrument looks like up in the picture there. It's an instrument that is made of rosewood bars, like a xylophone or marimba, but they're in a very unusual shape. And for those of you who might be interested in the setup of them and the length of it, 74 inches by 41 inches, and it's set up in a diamond. One of the things about it that's interesting is it could be played by 1 or 2 people. The pitches are not labeled. They're labeled here for you if you want to know about them. They're not labeled. You can just kind of go and play on them as they are. And that's the setup of it. The other thing about it, that the maker of the instrument, it's made by a company called Marimba One. That's a company that I've worked with quite a bit in California. They're up in Arcata, and they make really the finest marimbas in the world. But this is their new instrument, and he is really interested in the wellness space and musical instruments designed for wellness. And so one of the things that he did was he completely changed the tuning. So you can read a little bit about it. You can actually purchase a Jewel Marimba in several different tunings. Our standard orchestral tuning, like if you go listen to an orchestra, the standard tuning for the orchestra is A440. And okay, some orchestras go up to 442, but he's expanded it so you can go up to, you can do normal tuning, or you can go way down to 432. And we're very interested in this because he has some research that's not super quantified at this point that says that 432, which is a lower unusual tuning, is something that might really resonate with our bodies. And maybe you've heard of some of the conversations around this topic. And so that's one of the interesting things about it. The instrument that we have in the space is 432. That's one thing. They're rosewood and tuned by the company there. The other thing that's interesting about it is that it is just intonation. This gets into the weeds just a teeny bit about music, but we made a switch to what we call equal temperament along with the piano. So according to our musical staff, there are no notes in between the notes on the musical piano, right? I mean, now in life, there are. We can sing a wide variety of notes, but as we in Western music have codified it, the notes on the piano, the half steps on the piano, are the smallest interval that we more or less recognize in traditional music. But that means that they're equally tempered. Just intonation, it means that it's different than that. It's that the distance between the notes are based on the naturally occurring harmonic series, our fundamental series. Again, this gets into the weeds a little bit technically, but what this instrument does is it has a different relationship from pitch to pitch. So, for example, the C to the D, or do to re, that you would hear on this instrument is going to be a little different than the instrument on the piano. And we're curious if that, if that makes a difference or not. We're curious to get more data on this. We have 2 Joule instruments, and so we may try to run another study that actually compares them. But that's a little bit about the instrument. It's all flat, and so again, you can. I mean, people are taking it to parties and to sound baths and all these kinds of things. So that's the instrument. This is a little more about the setup of the space. This is in the Nova Lab, which is over in the School of Public Health. We've set up a 180-degree screen and then mounted 2 projectors to the ceiling. Eventually, we'd like it to be, completely immersive, but all around for the pods if we go into production. But the screen is there, and then these are some photos of Michael Bruner, who was here in the last hour. We're trying to get the 2 projectors to seamlessly connect. So the 2 projectors are there and going onto the wall to align them. And then we have a speaker system behind the screen to give the sound and project some sound effects that will be from the nature, leaves, whatever's on the screen, if there's water or if there's birds, this kind of thing. And then the instrument will be in the front. There will be a rug as well, and the lights will be off. There'll be a little bit more ambient lighting from lamps, but that's a little bit about what the setup looks like. This is the team. So myself, Dr. Jay Maddock, who is doing all kinds of amazing things over at the School of Public Health and is the director of the Center for Nature and Health. Michael Bruner, who I mentioned, who's a PVFA faculty of ours. Dr. Charlie Hall, who is the Ellison Endowed Professor of Horticulture. Ariana Pikus, who is in Human Development. And then Ziana Blackwell, who is in Prevention and Population Health, who help with the health services component of it. So those are all the people involved in the grant. This is my last slide. It's coming, and we'll definitely post it far and wide, but we are looking for participants. We'll be looking for lots of participants. This is the flyer for it and how to participate, and a few other photos just of the Joule marimba and how it's currently being marketed as an instrument that connects with nature and all of that. Our IRB study is there, and some of the benefits and risks involved. I mean, it's a minimal risk protocol. If you're interested in any more about it, my email is there and my website is there. And with that, I will pass along. Next is going to be Dr. Jay Lee, and let's see if yours, yeah, and she's going to bring up your slides, and I'll hand it off to you.
My jacket is so tight today. I'm sorry, guys.
That one is just to record the audio, so you can just pop that. If that's, sorry if I'm just like jumping in and you can just sit it in your pocket if you want.
Gotcha. Yep. Here we go. Howdy.
Howdy.
Thank you. My name is Jungju Lee. I go by Jay Lee. So I'm an assistant professor in the Department of Environmental and Occupational Health, the same department with Dr. Jay Mehta. So I'm working with my team in the Center for Community Health and Aging in School of Public Health at Texas A&M. So today I want to introduce healthcare, digital healthcare using virtual reality. Are you ready? Yeah, let me introduce my background briefly. So I studied at Indiana University, focusing on chronic disease management, such as diabetes and dementia. And my PhD minor is in quantitative methods, Bayesian statistics, longitudinal prediction, and machine learning models. That is my specialties. All right, the first project. Meditation using virtual reality. Our team applied virtual reality technology in mindfulness exercise, which is meditation, for emotional regulation and mental health among inpatients with behavioral health issues, bipolar, schizophrenia, suicidal ideation, and some kinds of depression stuff. So our research team completed these pilot studies and published 2 research papers with my wonderful mentor, Dr. Junyoung Kim, just over there, white shirt skies. Yeah, let's start. All right. As in my doctoral study, as a part of the program, I completed my clinical internship for 8 months in the psychiatric unit at IU Health Hospital, Bloomington, Indiana. The facility is located in this area. This unit is locked down the facility. And they are our participants. They had bipolar, schizophrenia, and many other issues, and they are taking regular medications. And they engaged in this VR meditation program for 12 weeks. And we found that the participants presented more regulated emotional regulation after 12 weeks of intervention. We use ECG to evaluate and measure their emotional regulation and track the changes during the 12 weeks of intervention. Of course, we use survey pre and post using MDD and GAD scales to measure anxiety and depression. Any questions? Yeah. It was pretty tough because in the psychiatric units, so we found that the people with schizophrenia are not appropriate for this intervention because after the intervention, they were trying to find butterflies in the unit, even though in the lockdown facility, because they cannot distinguish from the virtual reality and reality. That in the next study, we decided to exclude the people with schizophrenia and bipolar issues because they have some very serious side effect after the intervention. All right, let's see what's going on in their goggle, okay, via meditation. Could you play this one? I'm sorry.
We get the idea. I just like this.
participants can choose their favorite background music and background nature scenery, whatever they want, and they can make combination and they can choose meditation program, PRN, you know. Okay, the second project is community-based setting. The first one is clinical setting, and the second one is community-based setting. Our research team provided a nature track program in virtual reality in many nursing homes in Bloomington, Indiana area. So that is, we tested efficacy of the immersive nature-based virtual reality on mental health and quality of life for the care facility residents. We completed the pilot studies and just published several papers on that. All right, as I mentioned, we provided this intervention in many nursing homes, and this is me in doctor study. So it was the orientation session, and I visited this facility, and I was embarrassed because I didn't expect it would be so crowded in this place, because that day was the 4th of July. So many people were drinking tea and chocolate and ice cream. I was so impressed. So anyway, I got orientation for the potential participants. And this is the intervention shot, and that yellow shirt guy is my wife. And during the summer break, it was really hard to find research assistant because research assistants, they don't want to work in summer without pay, you know. So I invited my wife just over there, and even though she is a top-notch concert pianist, so I invited her to support my project and provide intervention in many nursing homes. All right, this is Nature Track in virtual reality. The participants can go to Snowy Mountain, White Beach, and Green Meadow, and African Safari, even though they are isolated in their rooms and their places. This kind of opportunity to get out of their boundary and get out of their comfort zone to experience nature things. Okay. This is a Nature Track app in virtual reality. Let's see what it is. They can make rain, change daylight, make butterflies, stop raining, make palm trees, make watermelons. I don't know why there is watermelons, but they may like it. All right, this is Nature Track in virtual reality. As I mentioned, the participants can go to White Beach and make palm trees and make butterflies. Yeah, even though they are in their rooms. Next, please. Okay, this is the last study. So this is intergenerational exercise in virtual reality. These participants is John Schneider. He is 87 years old, and he moved into the nursing home just before the COVID, probably between the 2020, 2019 probably. And not yet, I'm sorry. Yeah, he has mild cognitive impairment, not dementia. We assessed their cognitive function using MoCA test. He got a 17 out of 30 scores. But the problem is that Mr. Schneider want to meet and see their grandchildren. The problem is their grandchildren is living in Cleveland, Ohio, but he is in Bloomington, Indiana. They are far from each other. So we decided to provide this virtual reality exercise with Mr. Schneider and with their grandchildren. So let's see. He's playing this with his grandchildren. Yeah, let's look at the adaptation strategies using virtual reality. Mr. Schneider has a high level of functional limitation because he got a total knee replacement surgery just 3 months ago, so he has a high level of functional limitation. But in virtual reality, he can play table tennis on the chair because there is a chair mode. And adjusting ball size, so all the others, they cannot hit the ball correctly. So in the virtual reality, its size, like a soccer ball or the volleyball like size, the really big size, is more easy to hit the ball in virtual reality. In the racket size, they can use and adjust the size of the racket in virtual reality depending on their functional limitation. Yeah, that is our intergenerational exercise in virtual reality. All right, thank you.
All right, Dr. Zena Trost. I would recommend no mic, but okay.
Okay, I thought it was a 10-minute presentation, and I'm very sorry. So, hi everyone, I'm Zena. I came recently to Texas A&M, and I decided to give a very fancy name to my lab, the Pain Rehabilitation Society Futures Lab, to emphasize that we mostly focus on pain and rehabilitation. And most of our studies actually look a lot like this. We focus a lot on rehabilitation from spinal cord injury, neuropathic pain, helping people with phantom limb pain, helping people regain sensory function. We're mostly supported by the Department of Defense, but I'm not going to be talking about any of that today. So this is generally what we cover in a nutshell. We got a little bit of psychology. We got a lot of applying VR to physical ailments, and we got a little bit of social justice. Now, to understand what we're doing today and why it's a little strange, I need to tell you everything about virtual reality and pain research in one slide. All right, so you're going to come away incredibly informed, all right? So what this slide is supposed to communicate, that 90% of what we know about virtual reality and pain is that virtual reality is effective for acute pain, pain that is of a limited duration, like a needle prick, or a wound change, or burn debridement. If you put VR on somebody's head, when they're having a painful stimulus, they will have less pain. Why? Because they are very distracted. Well, the mechanism of this is distraction. So the golden grail in virtual reality pain research is not acute. It's all about chronic pain conditions. So that's what we do. We focus on chronic pain conditions. But what if, even though distraction was not the goal was an acute intervention, an acute moment where you can influence a person at possibly the worst moment of their lives, a moment when they almost died. So I don't have to tell you that the opioid epidemic is a terrible thing. I don't have to tell you that opiate overdoses are actually on the rise. The good news is that we have medications. We have opioid agonist therapies like buprenorphine that can effectively help people stop using drugs, help reduce cravings, help people get into recovery. The problem is that most people don't want them. The uptake is very, very low. It's about 11%. And recently, there's been a lot of focus on the emergency departments, because emergency departments are the place where these people come, right? They're there. We have them at our disposal, right? And so they're seen as these vital points of contact, and there's been increasing efforts by the NIH to be like, get them there. But even there, people are not interested because of a variety of barriers. And so part of this, and I'm not going to go into a lot about this theory, is that when you're making a choice, when you're evaluating an opportunity, emotion really matters. If you're in a bad mood, I don't know if you've ever been in a fight with somebody, if you're in a bad mood, if you're angry, if you're anxious, you are not letting new information in. You are making very conservative choices. You are going with what you know. If you're in a good mood, your cognitive aperture opens. Suddenly, you're able to evaluate the benefits of an option. You're able to see positive outcomes, right? You're able to imagine yourself in a better place. So, where does VR come in? So, this is going to be about the development of a study where we're putting on head-mounted displays in people who have just had an opioid overdose in the emergency room. Why VR? Because we know VR does several things very well. We don't know if it helps with chronic pain, but we know that it puts people in a great mood. Even if the movement in VR is causing them pain, they come out in a better mood. We know that this is possible because they're actually transported to a whole different place, possibly not a place that is aversive to them, like a noisy VR, like their own uncooperative bodies, right? VR can also give people agency, even if they're connected to a lot of medical wires, even if they can't move, even if they're paralyzed. It can give people agency. And this is very unique about VR, it can simulate a future for you. It can show you a future. So this study is called VR Choice. It's a collaboration. It's actually led by Yale Medical and Bayside Medical. It's funded by AHRQ. And we wanted to talk about giving people this option. So what is the study? How is it going to look like? So when a person comes into the emergency room and they have been stabilized because they have almost died from an opioid overdose, a doctor or provider is going to come to them and say, here's something that we developed that could potentially make you feel better, and afterwards, we're going to talk to you about treatment options. The goal of this is not to get people off of drugs. The goal of this is to get people to talk to their provider, to open them up emotionally, to talk about options. And we conceptualized it with the help of 51 people, and by lived experience stakeholders, here I mean people who are in recovery or are not in recovery, active drug users who have previously overdosed, across several states, because we didn't just want to have, like a bunch of white people over here. So we conceptualize it in two parts. One of them is called Mountain Journey, and one of them is called Possible World. Mountain Journey is a simulated ascent up a mountain. Why a mountain? Because we are going for the feeling of awe. Why the feeling of awe? Because awe is an emotion designed to accommodate new information. Like, look it up, that's actually what the point of awe is, right? And people, some very helpful people and our colleagues in Italy have previously examined what most contributes to awe and its mountains and its vast space. Right? The other is that we spend a lot of time, my poor lab students, focusing on how to get up the mountain. Do we float up the mountain? Do we control our gait up the mountain? Why? Because we've just had an overdose and we're very nauseous, right? So that took a lot of time. And so ultimately, it wound up looking like this, and I'm not going to take you through the whole 3-minute experience. We're going up the mountain. And eventually, we're standing at the top, oh, that's not pretty, at the top of a beautiful sunset. We have piloted this This does induce awe. Sorry. And at the top of that, people encounter
In any bubble you've already explored.
9 bubbles.
You're ready to finish. Touch the exit bubble to end the program.
And there are scenes in these bubbles, and they get sucked into the scenes. Let me tell you about those bubbles. Those bubbles are the possible worlds. Those bubbles are themes derived from interviews with stakeholders about what they would like to see once they're off drugs. And this is what 50 people wanted to see when they're off drugs. A lot of themes of being accepted, being seen as a real person. And so this is an example of the different little bubbles. We actually created 180 degrees immersive video scenes where people are referred to in first person. And so I'll show you an example of that. So here they get sucked into the bubble. Come on. Okay.
Yeah, it's been a good week. I'm super excited to share how this work has been going this week, honestly.
This is acceptance into the recovery community.
Yeah, there were some challenges last week, but we were able to pull through. These sessions, they really do help.
They do, yeah.
Hi. Hey, I'm Carol. Hey, Carol.
Hey, Carol, nice to meet you. Glad to meet you.
Thanks. It's my first time, so.
Awesome.
It's great. Just kind of matters that you showed up.
So we worked a lot on how to frame these things. We didn't want to be in person's face like, hi, in the camera. We wanted the person to be a little bit on the side, but still be engaged with. It feels very real. So we have piloted this right now with 20 people who are in recovery or not in recovery, but not in the emergency room. People like it. They think the bubbles are relevant. It inspires feelings of awe. It reduces those feelings. It increases inspiration, attentiveness, and determination. We're about to start trialing it with people who have just had an opiate overdose. And that's our cool little step.
Transition to Brian. Do you want to switch?
Howdy everyone, my name is Brian Kim. I'm an assistant professor here at PVFA and I specialize in game design. And especially my research revolves around game design for health. And that's why I wanted to share you about how to create a mechanics that would support more of the therapy session instead of points and leaderboard system. Because a lot of times, I know y'all been disappointed for the gamification term, kind of like metaverse term was really widely been used and now it's dead. Kind of like gamification was that too, like 20 years ago. And then there has been a lot of great clinically proven games, but at the same time, sometimes whenever you played it, it was just points and leaderboards on top of the therapy. And then I know y'all been disappointed because I was disappointed too. I thought maybe a lot of designers didn't understand what game design is, like game design method is, but in reality, it wasn't like that. Because whenever you create like commercial game design, you can start anywhere. You can be imagining the dragons, sci-fi, all these other cool stuff. But whenever you try to design a games for therapy, there's a really huge gravity towards clinical requirement, which you cannot escape. So a lot of times you kind of go for the results driven, like, oh, we should have more great results from this game. And then it loses both the attractiveness of video games, but also as a clinical tool sometimes, because although it seems like a great clinical tool, you'd rather sit with someone that you know and then talk with doctors instead of looking at monitors or VR system that you're not familiar with. So that, so what I tried to do was I actually created two different types of healthcare games. One called Emotion Adventure, which is mobile game for autism spectrum children, and iRehab for a VR game for rehabilitation for eye deficit patients. So today I'm going to focus more on how I approach, develop these games and kind of post-mortem it through to share my mistakes to you so you don't have to go through like me. So first one, I did what everyone did, which was create a reality simulation first and put game elements on top of that. That was really the simplest approach I could do. It was widely been known and then used, so I tried to do it. And whenever I created this, it felt like just a text-based button-clicking game, which was kind of not interactive at first. I did that with Seoul National University Hospital. They had the similar software per se. It wasn't a game, but they wanted to make it into a game. But it was pretty educational, so children knew the content of itself, having more buttons on it. But at the same time, engagement and generalization was really low. So we looked into the current competitors. At the time, there was Endeavor EX, the first FDA-approved game for ADHD. And what they did was they seek out the video game mechanics, the rules first, and then put the therapeutic outcomes or environments on top of it. So they tried to balance that out by those two. So we also did a similar approach where we find a game mechanics could support that theory of mind teaching dialogue better. We found some games like Ace Attorneys or Magic School Bus Simulation, if you remember that, and put that into mechanics. And the environment was more therapeutic focus, which revolves around the classroom. So we did this with 13 children, and then we also collected data like card use, dialogue choices, but also movement inside the game. And it was pretty good after doing the survey because they were, oh, I was really engaged, I loved it, I played more than just a regular therapy session. But one of the downfalls for this approach was it did not generate the behavioral change going further from education, meaning that they know what's going on, the content itself, but they didn't want to like do the behavior as such inside the game also, which is generalization, which y'all already know. So with the next prototype, I try to come up with, try to experiment with more with VR rehabilitation game. So at first, I did the same approach, seeking video game mechanics that would support the therapeutic outcome more. And at the time, we had the fellow from Houston methodologist who graduated from there, and then he gave me a really great therapeutic interventions, which was really close to arcade game, yes, you might already know. So we imagined that, okay, though there are so many arcade games that are similar to the current intervention style, so let's make it into VR arcade game, which was really effective. But at the time, the similar downfall happened where they enjoyed it, but they didn't do the same movement around outside of the game. So our team kind of looked into how the Endeavor EX, that game, was doing. And then whenever I found the reviews, although it was clinically really great and research paper were great, people were saying, oh, it just feels like an adaptation because since the game mechanics is same as a commercial game, they could find the better ones that do the same effect for me. So, okay, maybe we can switch the design process as so, like, maybe action needs to be simulated and really copy the therapeutic action from the traditional intervention. And video game environment should support that action instead of the other way around. So whenever we experimented with this by creating this game called iRehab, it was really successful in both ways because, as you can see, even to navigate the menus and around the game, you need to use your gaze and peripheral visions. And we had some mini games and environments that's more unrealistic but tailored to fantasies of the patients. And from this, we had like 2 participants and we had 3-week home play tests and we gathered up some data. And then we found out that it was really effective. So for example, previous female patient didn't have the really eye alignment here, and after that it went more left towards after playing our game. And this test called Lancaster test, where this is the black box is the ideal vision field, and it's not aligned here, but after it's more aligned. So what we found out is that, okay, so instead of just seeking for game mechanics or putting on top of it, we should define the core therapeutic action and make that core of the game and simulate the therapeutic mechanics and then integrate the aesthetics and dynamics, which the environment around that mechanic to create balancing engagement and clinical efficacy at the same time. So this is one of the research method that I focused on because I'm more of a game design person, and thank you so much for listening.
Well, thank you so much. If we could have all the panelists join me on stage. We have about 15 minutes left, and I'm happy to ask some questions, but we'd love to open it up first to you all to see if there are any questions for any of us individually or anything you'd like us to answer collectively as well. Anything that anybody'd like to know? Yeah.
Okay. Hi. Oh my gosh, I really loved hearing about all of your guys' work because I'm a technology gaming specialist at a pediatric hospital. So I utilize video games, virtual reality to try to create solutions for patients to reach various different goals. So I'm hearing from y'all's work, y'all are dealing with mental health, dealing with rehab, dealing with measuring pain and measuring anxiety, which sometimes is really hard to measure. I guess I have a few questions for you guys. One, for the rehab project that you're working on, is the focus now more so, are y'all still measuring pain or trying to figure out how to reduce them, since maybe addiction, opioids, not trying to administer that as much? So using VR as a avenue to reduce the need, not altogether, but reduce the need of having to utilize opioids, or is it more of an empowering type of piece of like, hey, after going through such a tragic event, you can feel empowered to get back on your treatment journey? Yeah. What's the goal?
So for that particular project, the target population are not pain patients.
Okay.
Pain is not, we don't measure pain in that study.
Okay.
It's strictly on people who have substance use disorder with opioids, so heroin.
Okay.
And the outcome, the main outcome is, so right now we're in the land of feasibility. Like, are people gonna wanna put this on their head in the ER? So I forgot to say this, but we did test whether people are willing to put a VR headset on their head in the ER and do like a meditation intervention. And yes, they are. They're bored. They're bored and angry. And so the goal is for them to engage with their provider and to like take in information. But I mean, yes, we totally assess pain in all our other studies.
Okay, good. Okay. And then also with the population, for all you guys that you guys worked with, it seems like there's a lot more emphasis or access to adult care. But I'm curious about, children, unfortunately, young teens, they deal with the opioid crisis, or they deal with mental health issues. And I've learned now at working with companies who try to intentionally design stuff for them, though it changes, those factors just alone, because it's a younger population, changes the content and how we produce it and how we're trying to make it engaging and interactive. So what are y'all's feedback on, seeing it with various ages in more of the adult sector, elderly patients, but how do you see what you're developing being able to be transferred for pediatrics?
I can speak to that for a minute. So virtual reality pain intervention actually came out of the pediatric space. So it's like the first intervention that was developed that was VR for pain at all was for burn debridement in pediatric units. So that's Snow World. It's like the most famous VR. And so in the pediatric space, VR is a lot more evolved because acute pain is like super salient in the pediatric space. So in rehab world, in pain world, VR is doing really well in the pediatric space.
I can kind of speak again about the children and adults because I did both. The main difference is the driving factor of using the experience. So adults, they want to get healthy. You know, they have a goal, so they will just do it. Although they actually told me like wearing VR makes me like a lab rat. I'm like, it's just a VR, but they were really didn't want to do it. But whereas children, they're always going for fun. So they're like, even though it sounds interesting, it doesn't sound fun. Although it's really good for them, they'll be, I don't want to do it, and then just go ahead. So one thing that I try to do with the limited amount of time was getting to know them, having more relationship with them first, and then let them try it out. That was the best way as a researcher perspective. However, I'm still trying to find like the design perspective of how can we let them come in to the platform instead of just playing Roblox or Minecraft. Well, there has been a lot of great mods and worlds that created inside those platforms, but they would rather play with friends in different server than the therapeutic ones. So that's a really tough question to answer, but from my experience, all I can do for now as a researcher was getting to know them and then say that, oh, this is really fun too, and then they will have fun regardless in that server or the therapeutic server. But that was my kind of answer to that hurdle.
I think there's like an important point you made, and this may be most relevant to your experience, which is like there's a lot of sort of bias that like older people can't use VR.
Yeah, that is a feasibility is really important to provide VR intervention in our study. You know, our main target population is geriatric population. The last project, that is the intergenerational exercise in virtual reality. That is a little bit aligned with the pediatric things, but from my experiences, the children and pediatric people like exercise, the physical activity using virtual reality. In other words, the older adults than children have different taste in virtual reality programs. So, but we are not developing program out on our end, but you guys can adjust and make design to drag some children to the virtual reality to provide and make environment to play together with their grandfather, grandchildren, and other people and more broad population using virtual reality. So we are considering to move forward our VR program with intergenerational design for geriatric population.
And for my project, it could really be on any campus. So it could be on elementary school campuses, it could be on middle school, high school, college, really anything. So I think it could go kind of across the board on that. So, Brian, you mentioned establishing a rapport when you were answering that question, which one of the things that I wrote down is the establishment of trust, or how the development of trust with your constituencies, your stakeholders, how does that play into your work? So you each sort of touched on it a bit. I'd love for everybody to maybe comment a little bit more on how what sort of methodologies or how you approach developing that trust with the populations that you're working with.
So typically we have people engaged in really long RCTs, randomized clinical trials, and we have to keep them engaged while technology fails and there's upgrades. And so my coordinator is sitting right there. So it's a lot of, 90% of that is that alliance you have with the treatment team.
And how do you establish that? in your work? I mean, do you have certain special things that you do, or?
Me?
Okay.
I just talk. I'm honest most of the time. If something's not working, I'll let the participant know. I try to keep them up to date, so even if I don't really have anything to update them on, I'll let them know that we're working. I guess, talk to them.
Often it's like engaging with people outside of, the specific measures and things we need from them from the study, because sometimes people want to tell you about their lives, and you need to hear them about their lives.
Yeah.
So.
Yeah, in our project, the relationship with the participants is really important because it's aligned with the retention rate in our project. So for geriatric population, they really don't like and they hate the virtual reality. Oh, what's going on in my head? They always said wearing a goggle, and they said, "Oh, I'm stuck. Please solve that." So we don't know what's going on their goggle. So I tried to provide pumpkin pie and some kinds of Thanksgiving holidays.
A little food bribery,
and
okay.
Make a small diary for them. It's kind of make an opportunity to make a good relationship. But sometimes it's really hard to get trust from the participants. I was bitten by a dog during my intervention. I have 2 holes in my shin on the right leg. Because during the COVID, our research team couldn't visit the nursing homes because they are locked down. So, we shifted gear to visit their house one by one, but we didn't know that they're almost all older people have their old and fatty dogs. Very not kind dog.
I see.
But they said, "Oh, our dog is so cute and kind."
He's not gonna bite you.
They never bite you. So suddenly, oh my God, it was bleeding. You know what? Even the bleeding in my shin, I tried to complete my intervention because, you can trust me and I trust you, even though I was bitten by the dog.
That's quite a story.
Yeah.
Brian, how about you? Do you have?
We already talked about patients, so I kind of want to talk about the stakeholders, especially as a technician. How do I communicate with the clinicians? Especially how I approach was establishing the same vocabulary and communication. Although they have some needs on VR or AR application, their understanding of VR AR to my understanding of VR AR is way different. Same thing for clinician too, where if I understand like autism spectrum children's theory of mind, I have read the literature, but their understanding of the material and my understanding is way different. If I just assume their needs and then make it would be awesome. It looks beautiful, but in practical sense, they'll be like, nah, that's not really the things I was looking for. And that's when the trust kind of goes down. I think it's, even though it's like a paper prototype or really not using VR, AR at all, I think it is important to like communicate the needs up ahead and then try to say, okay, is this the one that you really need? Because sometimes I made this mistake of them hearing what I'm saying for this intervention is, I'm gonna replace your role. It's not like that, but if I just say like, oh, this is gonna be really great, and sometimes they will hear like, oh, wait, you're trying to replace me, that doesn't really happen in real life. So I think building that trust through communication, not just a communication at high level, but using the same vocabulary as like agency or patients or guests or players, like even starting from that was really helpful for me to gaining trust with the stakeholders.
Great, thank you. Are there other questions? Yes, Susanna.
Yeah, I'd be very interested in learning about how you make aesthetic choices in terms of the visual, the form, the colors, the style. So some of you might use film or photographic imagery, others more comic style imagery, or you might draw on impressionism or any kind of artistic style. So what are the choices that are involved?
For us, it's driven a lot by how we want the thing delivered, right? So if we have somebody attached to a computer, we can run some really heavy graphics and have like great realism. But if we want just a headset available to throw on a patient in a unit, we have to create simpler graphics that balance like realism and aesthetic, you know. So, and that's one of the issues with communication with stakeholders, because like people have a belief about what VR is, and they'll be like, well, this is not very realistic, and you're like, well, you want it to be light and portable, you know. So that's one major thing that influences our design.
And for my project, patience was really the main factor of aesthetics, especially for the autism spectrum one. We first started as a realistic metahuman-like models, and because it is important for them to learn the emotion and the facial expression, but they were scared the hell out of it, like, oh, I don't want to see them. So that's why we made it into more comic figure, which ease them into learning more about the realistic human. And same thing for visual deficits, where since they have a blind spot all around, they need more flashy color sometimes, not like all the time. So that kind of drove all the aesthetics for me. But I think the budget and the capability is really about one of the two things that are really important to select the aesthetics of our experience.
Yeah, I'm in School of Public Health. I do not develop and adjust the VR apps and graphics because I'm trying to focus more about the clinical tests and the clinical efficacy. But of course, our research team is trying to secure the research grant, federal grant to develop our own program. Also, I'm open to collaborate with others, of course.
Okay. And for me, we chose film. Well, on the music side, we wanted, when we first had this idea, we knew that it had to be an instrument that was a very, very high quality instrument, rather than a toy instrument, for example, or something that could be perceived as a toy. We wanted people to really feel like they were having the chance to make real music in that way. So finding an instrument that was of that quality, and also easily played by anybody were two factors, and not just a drum. I'm a percussionist. I love drums. We wanted something that had more opportunity for melodic and harmonic playing. So that's what brought us to the Jewel, and of course its unique properties. We chose film because we wanted it to be as real as possible, and so for the cityscape, the decision to do a follow, like a single person follow cam in a city, so you actually felt like you're walking in a city. For the nature, on the screen you saw the sample that was more the autumn colors, but the entire time in nature will span several different colors, realms. There'll be some water, some autumn, some green, forest walk type thing, so we get as much variety as possible. But film at 4K to be as clear as we could get.
I do want to say that what you're bringing up is a really important issue, because we're talking like none of these decisions that we're making are like empirical exactly. Well, I think you have more basis in empiricism than we do, but like in pain world, right? There's been no research to be like, what if you put people in a virtual green environment that is digital? What if you put it into like a film? What if you make it more abstract? Does it actually make a difference? That has not been answered.
That's an interesting question, and something interesting to consider. Yeah, we're almost out of time, but sure, Donna, and then our guest. Yeah.
I was just struck with a lot. I mean, there's so much reliance on being in nature without being in nature.
Yes.
And it felt like there was a very strong argument in a lot of these circumstances for, I mean, I can speak in an ER, that's not possible, in certain political environments. But what you said, Brian, made me think that, maybe clinical protocols are preventing us from doing the most obvious things. Like, I'm now watching this and I'm thinking, we need more gardens and parks. We don't, because then you actually have the warmth of the sun and the sound of the birds and, the crispness of the snow or whatever it is that you're encountering. And I guess I wanted to know, and I think you answered to a certain extent, like, to what extent are you trying to navigate this barrier between the clinical isolation and the reality that not only do we spend most of our time in, but it's not like that people prefer to, you know, and maybe AR plays a role in that. I don't know. I mean, I could also see like having they advertise the marimba, right, in the forest. Are you considering having a version of that?
Yeah, that in my particular case, that conversation came up very early because, especially in working with Jay's group in the Center for Nature and Health, I mean, we concur and agree that the best way is to be out in nature wholeheartedly in the real. In this particular long-term idea, we want the choice of multiple environments that could be available to campus goers anywhere. So, for example, I gave the beach example for students here. In encountering students, mental health, one of the things could be homesickness, one of the things could, you know, so we want that variety in our eventual product that we hope to make. We want that variety of, you could go book 20 minutes and play the instrument at the beach in Cabo, or wherever you're from. Let's say you're from the Florida beach area or whatever, or even Galveston or whatever, that you could then have that environment that gave you that. So, but it's always been a part of the conversation for sure, and something that we're trying to be cognizant of. But in my particular case, we want more variety with the nature component, and so that's why we're not doing it outside.
Yeah.
But I don't know if others have other.
Yeah. And basically my research is more on the generalization of breaking those barriers, because especially in gaming world, there's like a really famous term of touch grass. You play too much computer, you have to touch grass and go outside. I think one of the reason is because mechanics are too tailored to game world, meaning that's why I research on mechanics that could generalize the action, what they're doing inside the game to the nature itself, instead of what's tailored to like slaying monsters, like double jumping, like Mario. That's only tailored to the video game experience itself. So as a designer, I'm trying to doing my way of, okay, there should be a way to design the mechanics differently so they could see, okay, oh, maybe I can really go outside and do something similar to it. One of the famous example is board game called Wingspan, where you just like have a bunch of cards of birds, and then you're laying it down, and then that made a lot of people go out and watch birds, surprisingly. And the mechanics were really similar to watching birds and reading their habits and then placing on the board. So those are the inspiration and then my research goal of actually going out into reality. Yeah.
Jeff, I know you had a question, but we're also out of time. But is something we can answer quickly, maybe, or we can also speak more afterwards?
What your time was at 1:45?
Yeah, but
Well, it'll be. I thought it'd just be interesting to y'all because from the hospital perspective, we have a lot of companies presenting some of these options, and some of you may have saw in my video that the patient had what they call the patient empowerment iPad.
Yeah.
And that was during COVID, and the hospital just decided to buy an iPad for every room. And so just in one hospital, that's 900. So when there's a real stress test, and you're looking for something people might invest in. The only challenge is that, we're an adult hospital, and it ended up, nobody really uses it that much. And you also have to have a cleaning protocol every time you use it. And it has to be charged, and it actually frustrated the nurses. And so they're still there, but they're in the cabinets. But I also think that it didn't have this kind of content. And there may come a time when something like that happens, and y'all might be ready. I think the question always comes up, well, it's expensive to buy a VR headset for every room, and also how do you clean it, how do you sterilize it when you use? Now, sometimes like in inpatient dialysis, where you have a lot of people in one room, they're looking for generalized content that will want them to go to sleep and want to wake up. And we just created some of our own content. There were speakers there and gave the the nurse the iPad, and it worked pretty well until someone stole the speakers, and then they just didn't do it again. They said, well, how could each individual space have it? Well, they couldn't figure it out because they're right next to each other. There are some producers in Nashville that have done several studies with us, and they're investing in building VR content, and with the idea that it could be used by hospitals or environments of care to reduce anxiety and stress, and they're betting on the content side, like they're betting on like a hospital will buy a subscription for the whole floor, and then everyone could download the content on that. But they're stuck with, well, they're just developing content for the VR thing. And we're not sure if the hospital's going to buy the VR things from it. And they keep asking, what do I think? I said, well, have the VR level content, but also have the iPad and the iPhone and everything. The only thing that really works right now in the hospital room is the QR code. In fact, they've noticed everyone has their own device. So my only advice, I don't know if there's a big market for that. I mean, because they also, well, our content's better than so-and-so's content. Well, that content's pretty good. And it's probably just going to come down to, and there's free content. But so the new hospitals are doing away with TVs in the waiting rooms. I don't know if they'll do away with TV in the patient room. And the newest hospitals at Methodist, they look like airport lobbies. It's all kiosks. You get a thing on your phone, QR codes. It's actually much nicer as a patient. You know, you're ready to go in 5 minutes and that whole thing. So we've shifted, I guess it's not really a question, but just sharing like real world what's happening in our market. Everyone agrees that there's great content. There's that challenge of how can it work effectively in a patient room. And our only advice is that develop the content so it can be at that level, but make sure you have all these other levels too, so it doesn't run it all. And what we are doing is fMRI tests with their content, just to show a reduction in anxiety compared to an ideal resting state anxiety. And we're happy to do the research, but when they ask us like about the market and stuff like that, I tell them I don't really know, but it's good. I think it's going to come. I mean, inevitably it will be there, and something will happen, maybe not as bad as COVID, where places will say, okay, we're ready to buy it, and then this whole arena will probably really grow. Anyway, that's just where I am.
Thank you for the feedback. Well, thank you, Brian, Jay, Zena. Thank you all so much. Yay!